So starting with today's session, we are able to offer continuing education credits, physician and nurses, and here are the required disclosure slides along with the code to text your attendance. And this will be available in the chat as well as on the recording.
And
with that, we can turn it over.
Great. Thank you, Elizabeth. Welcome, everybody. My name is Gene Bowman. I lead the clinical trial efforts in the Brain Nutrition Lab at the McCance Center. And I'm delighted today to welcome Dr. Dorene Rentz, a professor of neurology here at Harvard Medical School and a practicing clinical neuropsychologist over the past 35 years. She has dual appointments in the Department of Neurology at the Brigham and Women's Hospital and MGH. And she serves as the co-director of the Center for Alzheimer's Research and Treatment at the Brigham and clinical core leader at Harvard Brain Aging Study and co-lead of the Clinical Outcome Instrument Unit of the Alzheimer's Clinical Trial Consortium. Her clinical and research interests have focused on early detection of cognitive changes related to preclinical Alzheimer's disease, as well as the impact of cognitive reserve on early detection. She's recognized leader in the development of novel cognitive outcome measures for secondary prevention trials and the feasibility of mobile technologies for assessing cognition in the clinic and the home environment. She also serves as the national work group organized by the Alzheimer's Association to understand the clinical meaningfulness of new disease-modifying therapies for Alzheimer's disease. And today, she will speak to us about detecting risk for cognitive decline, feasibility and utility of remote digital assessment tools. Welcome, Dr. Rentz.
Thank you, Gene, and thanks to all of you for inviting me to speak before you. I'm going to try to share my screen if I can here. Here we go. Share. All right, can everybody see that?
Looks great.
Okay, great. I'm excited to talk about this topic because this is the wave of the future. We're going to have to be able to do cognitive assessments in the home environment. And I think that's going to be really important for us. So let me just get started and remind all of us where we've been. These are original phones and portable devices over the years. I've seen the phone from the 1960s, but I owned a Palm Pilot and many of these other instruments that you see here, which is actually kind of fun. But it's also important to know that medicine has been using these digital devices to monitor blood pressure, glucose levels, AFib, sleep, and that many of these kinds of the data is actually transformed to the EMR and really available to our clinicians or physicians. But it's also interesting to see if any of these digital tools can be used for the detection of AD biomarkers very early in the stage of Alzheimer's disease. And we know that our traditional standardized paper and pencil tests are really good at being able to detect normal from MCI, but can digital tools bring us closer to the detection threshold of these very early changes of AD biomarkers? So that's what I'm going to be talking about today. I want to talk about these next generation outcome assessments. I'd like to speak to you about the very first one that was used in a clinical trial and also in the home environment, which was something I put together many years ago, probably in 2010, because it was at the time that the iPad was first introduced to the public. I also want to talk about the mobile toolbox, branch, TabCat, digital clock drawing, passive monitoring, and how any of these tools could be used both in our research and also in clinical trials. I put this review article up here because it just got published this year, and it's really a review of all these remote and unsupervised digital cognitive assessments in preclinical AD. So those of you who are interested, check that out. What are the advantages of these remote digital tools? I think remote-based technologies can provide more automated and frequent assessments of cognitive and functional change in the individual's natural environment. So this greatly reduces the burden of in-clinic visits, enables participation of individuals residing anywhere, and allows for multiple assessments within a shorter time frame, which can increase reliability of change over time. I think this has a wonderful advantage over these every 6 months or yearly in-clinic visits. And we're just now beginning to explore all the many advantages that these remote tools can give us. But this is the iPad, the version of the C3, as it was called. What we did in this particular study, which was published in 2016, is we took this iPad version of the computerized cognitive composite that was used in the A4 study. It was used as a secondary outcome measure because we had no idea how these computerized tests were going to perform in a clinical trial. And I had a research assistant at the time, Maria Deckert, who I encouraged her to send it home to people because at this point there were no remote use of these particular tools, and I wasn't sure if this was possible. Now, this is at the time where we actually bought iPads and we sent them home to individuals. So this is before the time when you can send somebody a link or to make an app. And what we found is that 49 individuals, they were 71 years of age, 20% of them were actually non-Caucasian, and 95% completed 7 of the 9 assessments at home successfully. So what was cool was that the at-home test was correlated with the in-clinic test, and there wasn't any significant difference whether you did it in the clinic or you did it at home. So this was like the beginning of the promise that these remote tools could be done in the home environment, which can then really open up this whole field of remote assessment. So let me start by talking about the NIH Mobile Toolbox. You probably are all familiar with the NIH Toolbox, but a few years ago, I was a multi-PI on this study with Richard Gershon and Mike Weiner, and they developed a mobile version of the toolbox. It's a suite of cognitive tests that were validated against the gold standard in-clinic tests, as well as the NIH NIH Toolbox. Only this is now administered via a smartphone in English or Spanish on an individual's own device. So that means it was developed for iPhone as well as Android phones. The data gets encrypted and uploaded to a REDCap MyCap platform, which is great because many of the academic universities have this system, including us. And it's a secure electronic capture system. And the other cool thing that you all should be aware of is that the data is instantly available to you. So you can download this data when you need in your own data lock or however you want to use it. It consists of 6 measures of fluid cognition. 2 measures are of episodic and associative memory, including my face name associative memory test that was put into both the NIH toolbox as well as the mobile toolbox. But the other cool thing about this mobile version is that it also measures the domains of executive functions, working memory, and processing speed. Some of the other tests are only like dedicated to memory, so this makes this a little bit more flexible to the research environment. And this is how it appears on the screen here. There are also 2 measures of crystallized cognition of spelling and word meaning. So if you wanted to get some measure of cognitive reserve, you actually could do that. The time it takes to do the entire mobile toolbox is about 30 minutes. However, and you can see here that many of these tests are highly correlated with traditional paper and pencil tests, including the PAC-5. So the PAC-5 is a measure of preclinical AD and sensitive to amyloid deposition. So you can see that there was a lot of excitement. Could we develop a PAC-5-like set of tests with the mobile toolbox? And that's what we kind of set out to do. Because that would be nice if you could do a PAC-5 without bringing somebody into the clinic to actually to do that test. So my postdoc, Rose Juten, who's now an assistant professor back in Amsterdam, did this study with us for a couple of years. And this paper was just published in August of this year in Alzheimer's and Dementia Diagnosis and Disease Monitoring. So look it up. But what our goal was to see, could we put 3 tests together of the mobile toolbox that could be equivalent to a PAC-5 that would take only 12 minutes to do, 4 tests, 15 minutes, 5 tests, 18 minutes, or 6 tests, all 20 minutes. And what we found is that there was a good correlation between each of these versions of composites, 3, 4, 5, and 6, with the PAC-5. Interestingly, the 3-test version was actually correlated with amyloid burden, and the 3, 4, and 5 version was actually correlated with inferior temporal tau. So there's a lot of promise here if you're really looking for early detection of cognitive change that can be done in the remote setting for screening. We also did some longitudinal tests. This was presented at AAIC this year. And we found that it was correlated compared to A-beta negative individuals. The A-beta positive individuals demonstrated decreasing mobile toolbox scores over time, and that higher neocortical tau was associated with declining MBT scores, but only in the A-beta positive group. So that is consistent with a lot of the other literature. It's the people who have both amyloid and tau longitudinally who show the greatest cognitive decline. And that's what we found with the mobile toolbox. I want to move on. And also, if anybody has any questions, please speak up. I want to move on to the next remote assessment that we're excited about, which was developed by Kate Pepp and Rebecca Amarillo, who are now both associate professors here at Harvard Medical School. And they put together the Boston Remote Assessment of Neurocognitive Health, which they call BRANCH. BRANCH consists of associative memory tests that actually track along temporal-limbic networks and are sensitive to memory changes in preclinical Alzheimer's disease. The test consists of digit signs, in which you have to, it's kind of like a digit symbol test, where you have to match as quickly as you can the sign. There's a memory test that you have to remember the price of a grocery. And then there is, again, the face name test that I developed. This has had such very good performance for us, and you'll see some of the papers I'm going to show recently, that this was actually put into the Alzheimer Prevention Trials APT web study, which is a trial-ready cohort put together by the Alzheimer's Association Consortium study, the ACTC. And right now, I've heard recently that over 7,000 people have taken this branch in the APT web study. So a lot of good data yet to come, but what we can say is that it is sensitive to these very early tests, and it can be used as a screening test. So the first paper published in 2021 actually wanted to test its feasibility. Can you do unsupervised mobile testing in an older environment? And this study was actually done not only in our well-characterized cohorts of the Harvard Aging Brain Study and other R01s that we have affiliated, but we also sent it out to people who are a part of a registry from the ADRC, or MADRC ADRC. And what you see here is that, again, age is the older you are, the less you perform well, but that's consistent across all cognitive testing. But a good correlation with the PAC-5, which was great, and also an association with both cortical amyloid and entorhinal tau. So again, a lot of good promise in a test. This particular test can be done either on a phone, on an iPad, or a link sent to your computer. So there's a lot of flexibility for the older individual depending upon the device that they have. So that makes it also very appealing to researchers as well as to participants. The next study was a nuance of whether or not you could use tests like this that instead of just getting a total score or time to completion, can you capture other types of neuropsychological processes of learning that might be sensitive to preclinical AD? So they put together a study in which you took these particular tests. They're about 12 minutes each to do the entire branch, but you did it every day over the course of 7 days. They've actually been able to reduce it to 5 days. And what this particular study showed is that people were able to take it. 97% completed all 7 days. They required an average of 12 minutes to complete the task. The only problems were that there was poor device response and finger taps. This occurs across all digital tools, I can tell you right now, because even in the very first study that I did in 2010 with the iPad, is that women who have long fingernails don't tap as quickly as you can if you don't have that. And so that's a problem with it. And there were a number of other technical problems that reported over using smartphones versus other devices. So as you embark upon using these digital tools, be aware that there are some issues. And we've also found that if you have a research assistant who's on call, who can answer problems, it can easily be answered over the phone, and people can easily be able to participate. The cool thing about this is that they were able to show that these learning curves were associated with the in-clinic cognitive testing over time. And you can see that there are learning. But the thing is the use of these learning curves. So this was a paper published in Annals of Neurology by Kate just last year. And what they found is that it's these learning curves. You know, there's no significant difference when you take something the first time. But over time, what you begin to see is that there is a separation between people with amyloid positivity, or particularly if you have amyloid plus tau positivity. You can see over time that there is a significant lack of learning that occurs in people who have some kind of amyloid or tau burden. This is really important, and I'll talk about this a little bit later, because there's always some argument among neuropsychologists that you should be doing alternate versions. And here we're showing that even the same version can be even more revelatory of changes that are occurring at these very early preclinical stages. And what you see is similar to what digit symbol has done for many years, is that the digit sign test shows the greatest separation over 7 days, but so does groceries and so does phoneme. So you can decide to do 1 test, 2 tests, 3 tests, it doesn't really matter. But the take-home message is that if you only do it once, there's no association between A-beta and cognitive performance, but it's over time that you can begin to see that separation. And part of the reason we were beginning to think about this is that in a clinical trial, frequently you're doing testing every 3 months, every 6 months, or every 12 months. But could you see an effect in a clinical trial that would be over the space of a week instead of waiting 1 year, 2 years, and 3 years to see that treatment effect? So that's something that is yet to be explored, but it does show promise that as we look at nuances of learning, we might be able to see a little bit more of what we're looking for in a test. Outside of Harvard, there are other people developing tests, and I want to bring this one up at UCSF. They developed the TabCat, which also explores executive function, memory, but also socio-emotional status, motor, visual, spatial, and language skills. And they found too that the TabCat scores, along with if you included p-tau 181, NFL, GFAP, as well as some demographics, show the highest area under the curve. So there's a lot of sensitivity to this kind of cognitive test in relationship to other biomarkers as well. They showed an 88% sensitivity and an 80% specificity for detection of cognitive impairment, but that it's the combination of the plasma and the digital biomarkers together that show the greatest promise for diagnosis and prognosis in ADRD. The other thing is that, we're very Alzheimer centric over by us, but they're very interested in frontotemporal dementia and other atypical dementias. So this, if you and your group are really looking at that, then you may want to think about this type of test as well as the mobile toolbox, because that also has tests of executive function. I've been working for many years, you probably know, on the digital clock drawing test. The clock drawing has been around in neurology ever since the turn of the last century, because it was first developed during World War I to look at penetrating brain injuries. And it's been a favorite of Edith Kaplan, who walked around with a clock pocketbook. And that I'm sure many of you have had your patients draw a clock. But what if you could digitize it? Could you get more out of clock drawing? And so I began working with Randy Davis and Dana Penny. Randy is from MIT. He's an AI professor. And Dana Penny is a neuropsychologist who is a colleague of Edith Kaplan. And they began doing clock drawing with a digital pen on all different types of aging and dementia groups. And what they began to explore is that what the digital pen can give you is how you draw the clock. So you can literally peer into the mind of someone who's actually performing the task to see how they do it. And they developed various different scores associated with the digital clock, not only a summary score of how you do the clock, but both for copy and command versions, you can look at drawing efficiency, information processing, spatial reasoning, and simple motor performance. And you can also see how they draw the circle, where they place the circle, how they put the hands in together, how they set the numbers around the clock face. All of these particular components of clock drawing can actually give you some really important information of how someone actually either successfully completes the clock or fails to complete the clock appropriately, even though it looks like to the common eye that it was okay. So you probably know I published this first paper ever on the digital clock drawing, looking at its relationship to amyloid and tau burden. And what we found is that in clinically, that the digital clock had an area under the curve of 0.86. The PAC at this point was a little bit better than the digital clock to detect differences between normal and MCI. However, an area under the curve of 0.86 is not bad, particularly when you're talking about a test that only takes 2 minutes to give, in contrast to a pack that takes 30 minutes to give. The cool thing about it was, though, that the digital clock was actually a little bit better than the pack for detecting amyloid positivity in those who are clinically normal. So again, a lot of promise. The problem with this, and I'll be upfront, is that it's not remote, all right? And you need a digital pen. So I'm looking for some of you younger people who are in the audience here to begin thinking about how can you transfer the digital pen to something that could be a little bit easier to do remotely, whether with the finger or whether with a stylus. Anyway, it's work yet to be done because we have a lot of data that Jesse Fu is now doing that's also looking at these various nuances using AI and machine learning. So let me move to that. Jessie Fu is over at MGH there. She's my postdoc who has now just become an assistant professor. And in her K99 ROO, she began to look at the longitudinal performance of the digital clock and found that in those with high amyloid burden, there was a significant decline over time in people who have high amyloid burden. So, it's one thing to get something that shows that at the cross section, but it's nice to be able to see that you can get this same effect over time, which makes it even more appealing for those of you doing longitudinal assessments or clinical trials. She also showed that there was a significant difference in information processing in longitudinally with entorhinal tau burden. Now, information processing is really associated with latency or hesitations. So it's people who take their time before they actually draw a clock, and in so that there's this hesitancy that comes about in being able to draw a clock, even in the copy version. She also then began to explore, and this is not published work, is to see whether or not your performance on the clock can predict who is going to accumulate tau over time. And she found that with higher baseline tau burden and worse clock performance, exhibited fastest tau accumulation over 3 years. So again, another prediction tool that you can get with just a 2-minute test. Again, shows real promise for the use of some of these digital tools. I don't want to ignore the fact that there's more to these digital tools than just cognition, but Gad Marshall and Mark Doubleman have been working on an ADL version of an assessment, digital assessment. And here they are actually mimicking the patient portal or our patient gateway. And so they are asked to do various health-related tasks, such as refilling a prescription or scheduling an appointment. And this work is still underway, but pilot testing showed good internal consistency and correlations with standard cognitive and IADL measures. And they're also now collecting data on whether or not these asset scores are associated with AD biomarkers. So I think this is very important because, as we all know, that it's the combination of cognition and function that is the most sensitive to decline over time in early Alzheimer's disease. And then finally, I'd like to just move us a little bit forward to passive monitoring, because in my opinion, it's these passive monitoring types of tests that will get us to real life meaningfulness, because they're done in the home environment. There's a lot of data that's collected on smartphones, watches, sensors that really are attuned to how someone is actually performing their activities of daily living. And I think this is where the most clinical meaningfulness is going to be found. The data now being collected with these smartphones is related to sleep. Some of you, I don't have an iPhone watch, but I know some of you can record your sleep. It uses GPS to record your location or how you're getting around the environment. Some new work is actually being done on changes in voice or cadence of voice. But they're also collecting data on how often you use your device, how often you talk on the phone. And that is a proxy for sociability. So we know that social engagement is really important for these early changes in Alzheimer's disease. And this kind of gives you a proxy of that, as well as your gait and your mobility and how you get around. I put this slide up here because there's been recent work looking at passive monitoring in Alzheimer's disease. Many of these are review articles. Some of them are related to Catherine Hackett, who is a postdoc with Mary Sano at Einstein. They actually did things related to getting around the environment, and they found that people were not opposed to the feasibility of that. And there also being a lot of other work being done here. So I'm happy to share these slides so that you can look at some of these digital papers that are out there. But we began looking at it as well. So in part of the Harvard Aging Brain study, we just put in a competing renewal again. And one of them is to explore these digital phenotyping passive monitoring tools. And we've been using MindLab, which came out of the BI. And this is the same tool that Catherine Hackett has used. And in pilot data so far, that's all we have, is there has been adequate adherence to tracking across 76% of the participants. Phone use was translated into screen time, and that the amount of time you use the phone was used to collect data on social engagement, as well as the mobility data of where people are traveling. So down here, you can actually see a map showing a single participant's traveling distances and significant locations. And it's interesting that Catherine Hackett found, this is pilot data for us, is that the less variability that you show in your travel is more associated with declining cognition. So when you're cognitively alert, you get out, you travel more, and when you are not, you tend to be more routinized and travel less. So I think that again, this is data that shows some promise. So yet to come. But I also want to end with some additional considerations to think about when you're using digital tools or even in your own neuropsychological batteries. One is this idea that you want to be able to get at the nuances of cognitive performance. Again, this is from the digital clock, and some of the components that you can get out of the digital clock is how long it takes you to do a task, how efficient you are at it, whether you make errors or overwrite yourself. There's also an information processing, the percent thinking time that you use, or the latencies, the latent variability. You can't get any of that with paper and pencil. And that many of these things are really sensitive to these very early changes, biomarker changes that we see in AD. For those who do Parkinson's work or with Lewy body, there's even the simple motor stuff. So you can look at and track how quickly they do something, how they initiate, how they stop, whether they have tremors or not. And then the thing that I found the most interesting in my early cross-sectional study was the nuances of how someone draw the clock face, how they place the hands, how they put the numbers around the clock face, and where they put the clock is all very sensitive to very early changes. So my take-home message here is that digital tools can really give us a whole lot more information than merely time to completion or a summary score. Another thing to think about, and I made reference to this, but here was a paper that we published that looked at practice effects in preclinical AD. And here Risa Sperling and I put together a project 4 of one of our Harvard Aging Brain studies. And we sent the iPad home. And so what people did is they did the same version over 12 months, and then 20 minutes later did an alternate version. And this is 12-month data. And what you can see is that when you use an alternate version, there's a lot of noise. No matter how good your test retest and Cronbach-Alpher is in thinking about how equivalent these tests are, you can see that they're not equivalent. But yet, when you give the same test over the course of the months, you can see the diminished learning effect. And that was a real eye-opener to me, because when you're doing something, when you're designing a clinical trial, I've spent a lot of time developing alternate versions to tests. And I can tell you that there's a lot of noise that can really cloud or mask the treatment effect that you might see. And while this has not been adopted yet, I'm still a proponent of using maybe the same version to look at learning curves rather than alternate version. And that is what Kate and Rebecca are doing in looking at learning curves with branch as well. There may be something to that, so it's something that I encourage you to think about. And then there's a work that Jason Hasselstad has been doing, and it's another way of looking at digital tools using a burst design. And what the burst design is able to do is to minimize, let's say, a first-time negative effect of doing a test versus a practice effect. So what he is doing is he's evening out the true performance by doing it 4 times a day in these extremely brief sessions. These tests are less than 1 minute. And it reduces the within-person variability over the long term. So it's really another way of thinking about this. It also reduces the influence of attentional lapses, fatigue, stress, chronic health conditions, because you're evening out performance over time. I will tell you, though, that Jason has fessed up on the fact that you have a lot of attrition with this type of test, because people don't want to be interrupted 4 times a day to do it, even if it only takes a minute to do. But it's another thing to think about if you're new to this idea of digital tools. Do you want to look at practice effect? Do you want to use a burst design? Do you want to look at nuances of cognitive performance? These are all things that digital tools can give you because they're done remotely. They're in the person's in the natural environment, and they're using devices that they're familiar with. So in conclusion, I want to say that when you're choosing any of these digital outcomes, choose them based on the neural networks of interest that you have for your research study or treatment trial. Don't just do it because it's popular. Don't pick the pack just because the pack's been used. Think clearly about what neural networks are being impacted by the treatment or the intervention that you're looking for. Remote assessments may be useful to assess multiple time points for capturing change over time. So that makes it really appealing to the researcher. And I've shown you that many of these digital tools can detect early evidence of AD biomarkers. They may be useful for screening prior to biomarker testing, but they have not been used for treatment trials yet. So that's something that to think about, that if you have a treatment trial, use it as a secondary outcome measure so that you can see how well these digital tools perform within a treatment environment. I'm a proponent of passive monitoring because it reduces the need for a study partner, which is one of the limitations of many clinical and research trials in aging. And I think it's going to get closer to clinical meaningfulness. On the other hand, you know that when you do passive monitoring, you get tons of data. You need to do some data mining. You need to be able to classify what it is that you're looking for. You don't just do it and then expect to see what and then be inundated with tons of data that you don't know what to do with. The work needs to be done in looking at its clinical meaningfulness. Some of that work is actually already done in MindLab, and some people have already made classifications with these passive monitoring devices. So a lot of work, but a lot of research, but it's exciting next field stuff. I think I've told you already, and I'm going to reiterate it, that the value of these remote tools is that it can move beyond accuracy and explore nuances of performance. But in essence, I think it's going to be the composite of these things, the cognitive, the functional, the passive monitoring, that's going to be more useful in measuring treatment effects in a clinical trial. But in essence, they've not been used in that capacity yet. So that's all I have to say, and let's open it up to questions or discussion.
Thank you very much, Dr. Rentz. If anybody has any questions, you can post it in the chat or raise your hand here. I have a couple questions. Go ahead, Rudy.
Yeah.
Yeah, just quick, Doreen, that was great. So great to hear this progress. If you had to predict, how soon might we see a digital outcome or even a passive monitoring outcome become a primary outcome? How long do you think? I mean, that'd be great if we could get there and make things so much easier, but how far away do you think that is?
I don't think it's that far. I think that as these tools are used as secondary outcomes so that you can see it in a clinical trial, that's why I encourage people to put it in now, see how it performs. I think branch is pretty close to becoming a outcome. A primary outcome,
Yeah, I mean, it's
love
about
to see it in my lifetime.
Yeah, but like, will the FDA accept that at some point, a digital
That's,
as a
I
primary?
think eventually they will. It depends on the data, you know. Look at, we got the pack approved by the FDA. No one
Right.
had ever done a pack before.
Yeah.
Nobody ever did it in preclinical AD. You know what I mean? And it was approved by the FDA. I think these tools are now showing some good association with amyloid and tau. What I don't know is whether or not if you remove amyloid or tau from the brain with some of these disease modifying things, will there be a change
Right.
in that digital marker? I
Yeah.
mean, we're already finding out that even our plasma biomarkers aren't demonstrating the kind of change that we would like to see. But you know, Rudy, I'm positive. I think that in 5 years, we're going to see it. Do you know what I mean?
Hope so.
I really do, because we can't keep doing the same thing over and over and over and failing. Do you know what I
Yeah.
mean? And we're not stupid. You know, you keep banging your head against the wall. It's not going to give you a different outcome.
Yeah.
But what these digital tools give us is another way of looking at performance that you can't get just with paper and pencil. So I
Yeah.
think that I think as more smart minds come together to do this, I think we're close. I see Risa Sperling's online here too. So how soon do you think we'll be able to do it, Risa? To use a digital tool. Maybe she's not on. I don't know.
Well,
Yep.
There she is.
I actually predict that the learning curve or other digital tools might make it before the passive monitoring, even though I agree with you. And I asked you a question about
the timing of those two. I think the issue with the passive monitoring and the FDA is the problem of control of who's doing what, because you have to verify who's actually doing it, and that is solvable. As you know, you can use fingerprints or face prints or maybe face voice print to do it. But the more identifiable you are, the harder it is to protect confidentiality, and that's where we're a little stuck, as you know. So, but I think we are embedding them. And in fact, you just convinced me during your fabulous talk. We, as you said, have put Branch in the APT web study. We're putting it in APEX, the longitudinal plasma study for predicting future amyloid positivity. And I think we should put some passive monitoring in if you're up for it.
Yeah. No, you know me. I always like to push the envelope. So I think it's the only way we can move forward is try, you know.
Yeah.
And what do you
Well,
think
great
about
talk. Thank you.
the timing of learning curves or your most sensitive um, neuropsychological test versus passive monitoring? Do you think you'd see the learning curve before you can detect passive monitoring changes, or are they simultaneous, or just theoretically? Because I know we don't have data to stack them up yet. What do you think?
I don't know. I think it depends on what the passive monitoring is, you know. The nice thing about cognition, you know, is that we can see diminished learning. Does, you know, so much of passive monitoring is habituated learning. Do you know what I mean? These are people are doing the same thing, you know, over and over. Jeff Kay and Hiroko Dage, quite a number of years ago, really talked about being able to get on the computer and to use it or to do their email. These were things that they were able to see in MCI. I don't know how soon that deteriorates in people at the preclinical stage. I think they may still be able to do that. But this is a wonderful R01. I think to be able to really suss out what is changing first in relationship to these habituated passive skills that we do every day. Another one that is a part of passive monitoring is voice, you know, so sometimes people have greater word finding, trying to get their words out in earlier stages of disease. I have a problem with that because people can have hesitations in word or speech for many reasons, you know. But it's an area of interest that is being explored in ADNI, for instance. So we'll have data related to that. It's a this is the frontier. This is the Wild West. We have yet to figure all this out.
I had a related question just about the timing. We're actively at the McCance Center involved in these high frequency fluid biomarker trials of relatively short duration. And I wonder if, we're doing high frequency testing of AD biomarkers, plasma, and how that might track in parallel with some of these digital tools, whether or not you might detect a week to week or month to month measure of p-tau 217 that could potentially be quite strongly linked to a bad day on the digital sensor or something along those lines, and whether there's any trials going on or longitudinal studies that are doing kind of these more frequent monitoring of blood-based biomarkers along with these digital tools.
Yeah. I don't know of any, you know, so I think this is really very cool. Risa, do you know of anybody who's doing that?
No, I think it's a good idea. The problem is, like, at least right now, without lowering the test retest of p-tau 217 exceeds the month-to-month change, even really good tests. So we hopefully they will get stronger and stronger. But I think it's a good idea to try to link them more frequently. And we are trying to do the at least branch and perhaps more every 6 weeks in some of our studies. And we do bloods almost that often, so maybe we'll get some of that. And I think we should do more tests, as Doreen suggests.
Yeah, maybe we could have a follow-up related to this and embed some of these digital tools in some of the trials we have planned
Yeah.
here, collaborate together. I think there's a remarkable opportunity because even Hiroko Dodge that you mentioned, who's a close colleague from Oregon years
Yep.
ago, now here, has come
I
up with
know.
a statistical technique to reduce the intra-individual variation of these plasma biomarkers to really detect the inter-individual changes amongst people given a particular treatment. So we have a paper that's going to be coming out relatively soon that she's leading on this SLIM method, which I think would reduce, Raisa, the point that you're bringing up about this, this intra-individual variation that's been a nuisance. But anyhow, something to talk about, I was thinking about during the conversation. Thank you.
Yeah. I think, though, another important caveat is if you're going to do that kind of work, make sure you pick the right tests that are going to be associated with the change you want to see in that blood biomarker. So, for instance, if you're looking at A beta and tau, you may want to look at memory. So things like branch are important. If you're looking at something else, you may want to pick executive function tools. Do you know what I mean? So I think that what happens is people will revert to a summary score and then wipe out all the variation, that or nuance that you really want to capture because it's all washed out, So I would say be really sensitive and thoughtful about what outcomes you really want to use to measure things. I mean, we're all like in behavioral neurology, so this is not a new thing. So don't just revert to using a summary score. Just be thoughtful about what you're going to use.
Thank you for that. Are there any other questions amongst the group? Dorene, this has been wonderful. Really, thank you so much. I'm so glad that you were able to come and this worked out.
Yeah.
I think it really is an opportunity to do maybe these early phase trials and early detection. Using these, having trained at Oregon Health and Science University, Jeff Kay's program, they've done a lot of passive sensor monitoring with Intel and kind of these living labs in people's homes, looking at the computer. So I'm familiar with that data, and I'm curious how we could utilize those type of passive sensors as well. So it seems like a really bright future for early detection prevention, primary prevention trials.
I totally agree. So I'm really pleased to assist in any way that I can, and because you guys are doing next generation stuff as well, so it's really important to collaborate and work together as a village.
Absolutely.
Yeah.
Great talk. Thank you, Dorene. So
Oh,
amazing.
thanks, Rudy. Thank you. Thanks, Teresa, for being here.
Yeah, thank you,
And thanks
Risa,
to
for attending.
everybody. Really
Yeah.
appreciate it.
Okay.
Okay, if there's